Imran. He also.
Great. Welcome to our QI project. So we're focusing on reduced operating room wait times. So we define the problem as this issue we perceive as being that operating room wait times are historically greater than 6 months. Typically, that's what we tell people when we're booking these appointments out. So we have a pretty long buffer to do a lot of the steps that are necessary in preparing that stuff. And so as a consequence, like all of these steps, trying to pinpoint places where we could make it a little bit more efficient, identify some bottlenecks to move the process along to hopefully reduce those times globally. We'll kind of go over a lot of the steps that are involved in the process, and then for the sake of this course, just trying to find one thing and focus on it, see if we could QI it. So, with our constraints, pediatric dentistry residents have considerable temporal constraints and existing responsibilities, resulting in challenges in collecting, completing, and submitting the necessary consultation forms that are needed before we can book patients for the OR. And so just a quick definition, what we're talking about, because it was unclear previously. So this is like, this document, getting to this point, there's several steps along the way. So this is our typical medical consult that we're sending out to specialists, primary care providers, things like that, just to have them review the medical history we have to make sure that it's accurate, and also get their input in terms of, do they think this patient is fit to be seen in an OR setting under general anesthesia? And so it kind of details the treatment that we want to perform under general anesthesia, verifies that they don't want to make any modifications, adjunctive medications, things like that would be necessary for a safe procedure. And like I said, verifies the accuracy of the patient's medical history. And so kind of what this project is focusing on is getting this information right here, which is 3 lines in this big old document, but it is like, it can be like an immense challenge. Yeah. The physician's name, their phone number, and their fax number as well. And we'll kind of talk about why it's so variable and why it's kind of a challenge.
Yeah. So just to kind of, for a lot of us who actually do this process, it's probably self-explanatory, but just to give everyone a sort of baseline before we go into the project itself. So typically how it works is that we, as residents, we see these patients for either consultations or new patient appointments, and we identify potential patients to be seen in the OR. They may be requiring extensive treatment, but they're not medically fit to do it in office with our general anesthesia options, and so we need to look at other alternatives. And so part of that first appointment is really doing sort of screening, trying to see what types of treatment will they probably need if we're even able to do that, get all the contact information with the specialists, and then get all the information, relevant clinical information for your treatment plan. So after that appointment is done, it's a 1-hour appointment, the resident has to sort of make sure that if there's any gaps. For instance, parents might come and say, well, I don't know the name of their neurologists, but I guess I could try and figure it out, sort of following up with them and making sure that they actually do call their hospital and find whoever they're actually seeing. Sometimes it's just a matter of Googling, but then sometimes we get multiple phone numbers, multiple fax numbers, that's not correct, and we might be faxing somewhere that doesn't exist anymore. And then it's like, we're back to square one. Or we're faxing somewhere that's not a correct number on it. So getting accurate information, which is, has something that many of us have probably experienced. So then afterwards, after this information, or concurrently, the resident itself is writing up the medical consultation, making sure that it asks and requests all the pieces that we need in order to treat this particular patient. And then afterwards, somewhere out there, the specialist, whoever they might be, is needing to respond to our questions, and hopefully they do that in a timely manner, but oftentimes it's at their own convenience. Sometimes that's within a day, sometimes that's within a week, sometimes they say they're going to do it, and they go on vacation, and then it never gets done, and then somebody come back from Christmas break, and then it's still not done.
Sorry.
And so again, forgotten consults, it happens. So at that point, once all the consults have returned to us, they fax back to us. Those consults are gathered, given to our OR coordinator, and then the OR coordinator is able to eventually book that patient.
Is the OR coordinator, they're part of Ronald Reagan, right?
No, they're right here. They're here in our section. Yes. And so this.
So it's Becky.
It's our Becky.
Okay.
Yes.
Our Becky.
AKA Becky. So this kind of just is a sort of visual representation of what the whole process looks like. And so this is just to sort of clarify about what phase we're specifically trying to intervene in. The secondary phase, where we're waiting for specialists to return things and scheduling that's really out of our control, or there's less control over that because oftentimes we have meetings with specialists and we can follow up, but it's harder to test and to implement any type of QI project. And so we decided to focus on what we can control, which is where the residents come in. And so it's more provider dependent and more predictable.
So again, our overall goal is to reduce this time based on all those factors we're talking about, is to try to get that overall wait time decreased, less than 6 months. And so our aim for this project was to have to have 90% of our patients that had initial consults, that their medical consults were sent out within 1 week of that initial appointment. And our part of that is to kind of implement the collaboration with our advanced clinical trainees, also known as ACTs.
Oops,
so this is,
wait, okay, my bad.
yeah, that's okay. Actually, can I?
Yeah.
Yes, actually, so when you guys speak, can you guys speak?
Oh, okay.
Sure.
Thank you.
So this is our root cause analysis, which incorporates the people, environment, rules, policies, procedures, and the actual process. So as far as the people component, that's basically the parents and the patients, as well as us on the other side. So oftentimes patients come in with their parents and they have medical complexities, and these parents are dealing with a lot, and it's hard to keep track of who these specialists are. It's amazing when they come in and have that list, the magical list that has everyone listed with their contact information, but that's very rare. And so oftentimes they come in lacking even the names of their physicians. So we have to do extra kind of investigatory work to figure that out. Sometimes they do know the names, and then we have to, but they don't know their contact information. And this is the sole responsibility of the resident to figure all that out to get the patient in the process of being seen in the OR. As far as the environment goes, that's kind of pertaining to, for instance, the resident schedules. So we're here during working hours, and since we're the only ones that are really able to gather this information, we're trying to work with physicians that have the same working hours. And so oftentimes when we do have extra time to be able to gather this information, no one's at the office to actually get back to us. So that kind of increases time. And then also we don't have that aspect of our program to have someone helping us do this. For rules, policies, and procedures, there's nothing concrete, but we do have these two aspects of our program where we have residents and also ACTs, and they're kind of different perceived roles of those two, of the two entities. And the process as a whole, there's a lot of checkpoints, and so that in and of itself is what makes this kind of a longer process, and that's why we're trying to intervene in some of these parts to make it a shorter wait time. And so all of that leads us to our problem of having a long OR wait time, outside of the fact that there are a lot of patients that need to be seen, which contributes to that.
Okay, so these are just some sort of metrics we gathered starting from January 1st of this year. This is just looking at data from the clinical appointments that we've had that are classified as either new patient appointments or consultations. So of those 123 appointments since January 1st, 12 of those were patients that eventually became confirmed, OR workups essentially, in order to be treated at Ronald Reagan. 6 of them required more, some a little more legwork with consultations before deciding that they'd be in the OR. 17 of them were decided to be treated in office with our general anesthesia, where we have our dental anesthesiologists come in and help with that process. 41 found that we could just treat them within our clinic with normal clinic hours, and then 47 of them failed their appointments for their new patient and consult.
For new patient?
New patient and consultation appointments.
That is not 40%.
Yeah, so it was just some interesting things there's some other QI projects that might stem off of this separately from what we're looking at, but just some food for thought.
It's also January, so
Could be. Though if we go back further, I don't know if we'll find something too far.
Yeah.
Yeah. Yeah. Okay, and so with this process map, this is sort of the workflow of how our project would involve the ACTs, as well as what the residents' responsibilities were. So we can start up on the residents. So first, they see this new patient during the consultation or new patient appointment, and then they identify, okay, this is going to be a patient that will require an OR workup. So if that's a no, it doesn't require an OR workup, then they'll be triaged into the clinic system. If yes, they do need to require a workup, then that's the info gathering process that we talked about before. And so at that point, it's a matter of collaborating and meeting up with one of the ACTs. Within our project, we focus in on just using 2 of the ACTs in order to sort of make it a little bit more realistic, because in past years, we've had 5 lovely ACTs this year, but in past we haven't. And so we sort of kept it on the smaller end of that. And so we inform the ACTs that here we have a new OR workup that needs to be implemented, and so then they join that case. Together, both the resident and the ACTs can sort of tag team and communicate, okay, these are the lists of specialists that we need to gather information for, and we need to be able to fax these consultations too. And so together they can gather that information. The resident can continue to write up the medical consults simultaneously, and then the goal is to submit those medical consults within a timely manner. And then within the scope of this, as the next slide will go into, it'll be within 1 week.
So our kind of driver diagram here, we've covered most of this stuff, but looking at it diagrammatically, change concepts we really wanted to address was reduce wait times, find and remove bottlenecks, like I talked about previously, smooth the workflow, have a standardization. We have that form that can help move things along, because it's always going to be essentially the same. It's kind of like plug and chug the provider-specific information and patient-specific information. Minimize handoffs. Every year when things turn over, inevitably, if there's things that are left in the queue that are not finished, they don't get completed, and then we don't find out about it until the patient comes back and they're like, we haven't been seen in the OR yet, and then we have to kind of do some digging as well. So we want to make sure that that just doesn't happen. Optimize level of inspection, and then reach agreement on expectations as well. So secondary drivers, we'll kind of go into, I guess we're going a little bit long, so I'm just going to, this is clear to y'all? Okay. So for our PDSA cycle, and we'll kind of look at our run chart next. So the plan was the resident of the ACTs would coordinate during and after day of the initial consult appointment. Residents will document time from the appointment to setting the appointment, so that we have hard time units as data points. For the due, ACTs will gather information regarding the specialist using Google, direct calls, Care Connect, etc. Residents will review consults and act as the point of contact before ACTs submit. And then the study, which we can see, I think we cover some of this stuff later. There was a 13% increase of residents submitted medical consults to specialists within 1 week of seeing patients. Evaluate barriers to completion of sending consults, like the communication process. And then we can evaluate the ACT's experience as well. The current format does not offer kind of like that room to grow, essentially.
Right, yeah, essentially they're not getting there's more opportunity for them to become more involved in the process, and we'll talk about that with future steps.
For sure. And then decrease submission time with the ACT's help. Repeat the PDSA cycle over a longer period of time so that we have more data, so we can really see the impact this is having, or if this is really an issue to begin with in terms of trying to identify bottlenecks along the way. We can also do a PDSA cycle on the resident. What information seeking tools are we using? Imran uses Google, you use Bing, and I use Ask Jeeves, so might get different results that way. And then we can expand and adapt the role of the ACT in the OR workup process. Continue to collaborate with the ACTs, and then address additional barriers along the way.
Okay, so this is sort of looking at a run chart between over the course of the period. Because of the nature of what we were measuring, getting a concrete baseline or an accurate baseline would have been more challenging if we sort of tried to go back in time. And so what we focus on is looking at some of the new specific OR workups that residents were currently working on and sort of seeing, well, how long did it take for them to send the consults? Like, when did they see the patient? Yeah. And when did they see the patient versus when did they actually submit the medical consults? So the x-axis is just the date, the y-axis is number of days that it required to submit, okay? And so our goal is to try to kind of keep it within a 7-day period, so that's so that it can be done in a timely manner. Now, what we're seeing with it was sort of an interesting thing where there's a number of residents who were already doing that, they're already matching that, but then there were some that weren't, and so we wanted to see, well, what other factors might be contributing to this discrepancy. So, there's one thing where there's just simple complexity of the patient themselves. Some patients require one medical consult from a cardiologist, others require one from the neurologist, the pediatrician, a pulmonologist, and lots of other ones. And so for that part, that wasn't able to be accounted for. But what we did do for keeping it on, keeping it.
Oh, no, you continue. I was just so that.
Oh, I wasn't stopping.
Yeah.
I wasn't stopping. I was like, it's more of a suggestion, 15-minute, right? We have to go through this diagram. This would took more effort. Anyways, so each of those points before represented one single OR workup. Each of these individual different shapes represents different residents as well, okay? So a yellow shape would be a first-year resident, and a light blue or cyan shape is a second-year resident, okay? So the second-year residents, as you can see during in the first, they're doing very well. And so what this might be is, knowing the system and having a good workflow with, moving forward. However, we see during the baseline period that there's some first years who are able to get it, approximately within 1 week or below 1 week, and then others who aren't. And so this might be able to target who maybe needs more help. Okay. One of the issues with testing this too was that we can't necessarily say that, oh, resident smiley face, we'll do another PDSA on them, right? Because they may not be the one to work up that next case. So for the purposes of this, we were just blanketly having, as part of the intervention, ACT support with getting that contact information. And so here what we see is that we do see most of them, of the 5 cases, 4 of them were within the 7-day range, 1 of them was slightly over. And so we did see an improvement on that. These happen to also all be first years, so it showed that having ACT support would also help first years who are still maybe trying to gather a sense of that workflow under their belt. The other thing is just to sort of clearly indicate the 2 different colored arrows represents the different ACTs. We're just keeping this very anonymous, just looking at it more objectively. Okay.
So as far as barriers that we have encountered or possibilities to encounter, so a rate limited, basically the PDSA cycles by new patients requiring treatment in the OR, just the point that Imran made. There's also the point that Imran made earlier about the varying degree of complexity. It's kind of hard to concretely study that quantitatively if you have different complexities of patients and consults that need to be sent. Again, conflicts between resident and ACT schedules. So we're doing things at different times and actually having them there to be able to access them and utilize their help. And also we're very sensitive to know that ACTs have their own schedules of stuff going on. So being able to work with them and do something, more of a synergistic effect instead of, taking away from other people's schedules. We don't want that to happen. Also inadvertently increasing the time to do consults if we have to kind of backtrack and explain certain cases. I think that would be a problem that'd be more focused on earlier on when we're kind of implementing this process. Again, getting them up to speed with the with the workup process. Another problem that could be encountered is if we're having ACTs follow up and call. Sometimes it's likely that the parents are going to be asking questions that might be out of their scope. So being able to kind of field certain questions And then again, the perception and support of this new kind of process of, expanding the ACT's roles. How would that, would that be okay with everyone? As far as future plans and steps, so of course we'd like a longer observation period to see the implementation of these changes. Something that we talked about originally was having like a script and a prompt for the front desk, so we can find out more about these consult appointments, so that we can get more information from the get-go. Possibly reducing, like it took us a couple months for us to get access to Care Connect, which would have actually sped up a lot of processes at the beginning. And hopefully one day allowing like the ACTs to be able to access Care Connect or Axiom so that they can see the patients that we're seeing. Using a spreadsheet for all ongoing workups so that everyone is on the same page and we can help each other out. Increasing ACT engagement in the consult process is something that we overall want, so that they're exposed to more, they're getting familiar with our patients. And again, that goes along with like the clinic, its procedures, all of our patients. And then again, the formulation of like a true care team and patient navigator. So not just one person that's directing this patient to the OR, it's multiple people that are guiding them and helping them out along the way.
And just like one more comment. As I mentioned before, there's different residents who sort of came along with different cases, and so it might be nice to sort of look at as sort of a control inherently, looking at the same resident for multiple workups, and so each of their workups in and of itself is a PDSA cycle, like what worked well here, what intervention can we do here, and sort of focusing on sort of looking at that instead of all residents together. Any other questions?
So I do have a few questions.
Okay.
And I think we only have 3 presentations. So I'm wondering, so when you're saying when the patients come in, or when they call in for an appointment, do you know that this is a complex case?
No.
A special needs, so you don't know ahead of time.
And that's a really good point, because that's why I had broken it up on that slide, because some of those consultations could be healthy patients who can easily use their clinic. Some of them might require general anesthesia, some of them might require treatment.
Oh, the ones that you did in the pre, so they're not all. Okay. You mean
No.
the run chart?
No, not the run chart. The slide that had the metrics about like 12
Oh, got it.
Yeah, exactly. So that's sort of illustrating. Afterwards, the run chart's solely patients who are complex medical that require treatment.
And do you all have? I mean, I know there's a lot of specialists, but is there a list of referring specialists?
So that also brings up a really good point, because for the medical consultations, if it's within the UCLA health system, that could also be a much easier way. It's much easier to get into that network, because we have Care Connect access. We can immediately message those providers and they respond fairly quickly. For those out of this sort of network that we have here, it becomes more complicated, and having accurate contact information is more open. So for UCLA Health, absolutely, we have the paging. Once we have the doctor's name, we can literally send them an email with the medical consult directly to them. But for instance, I'm doing a case right now that required 4 or 5 consults outside of Bakersfield hospitals, and it required getting specific information and getting all those concepts.
I mean, I'm just thinking there's probably only a limited number of pulmonologists or.
So we have patients that come from a 2-hour radius from all over, so you really never know where you're going to get.
Okay.
Yeah, there's some recurrence.
I wish it was that easy, but it's just, it's not.
Can you go back to your PSA? I wanted to just have you elaborate a little bit on the sort of study section in terms of your learnings on that, and like, did you sit together with the ACTs and do this? Was it asynchronous? You gave them a list and had them find stuff, and what was your takeaway in terms of, I mean, I saw your results, but in terms of your experience of what's the added benefit of the ACTs in this process?
So to answer your first question, you're asking for, let's say we get the OR workup, what's the process, like what do we do with them? So it's mostly getting, communicating and sort of seeing where are the gaps in the knowledge, or the gaps in the contact information.
But how did you work with the ACTs to do that? Did you give them a list? Did you guys decide, okay, we have this, we need this, you go ahead and
It was
It's case by case.
It's
So
case by
if
case.
what we know, the information that we need. So we had a meeting with them before we implemented to explain like what we wanted to do with them and get them on board and make sure they were okay with it. And then as far as when we had, a consult that could use their help, we let them know when we would have consults, and if it's something that they could help us with, we gather as much information as we can at that consult and then hand off the information that we have and the resources that they need in order to figure out more.
And then
So
as far
using
as
Google,
yeah.
giving them the names, giving them the contact information for parents so that they could call to find out more information as well.
And then as far as the means of sending that information as well, it would vary too depending on when that consultation was during the week and where they were based on their own schedules. Each ACT has their own
so they would
service
have a
schedule.
list of what they wanted to get, needed to get,
Yeah,
and whenever
exactly.
they could
Right,
go and do that.
Exactly.
So those details are important to document. And so if I see, let's say you did a poster presentation or something, and I'm like, oh, this is a good idea, and I want to try this. I need to have those details because it matters, right?
Okay.
Because if you have, particularly because you have time constraints, like those are real things that everybody does. So how did you get around that? Those kind of things are important to sort of flesh out. That's good. And the other thing I was wondering, so when you talk about the 6-month wait, like in my mind, when I always heard that, it's like, oh, the OR is just so busy that we can't get in.
That's part of it.
But what this project is implying is that there's a lot of things that need to happen before they're ready for the OR.
That's
to
also
be
part of it.
scheduled, right?
So that's a great question.
What's that?
Right,
Sure,
exactly. Yeah.
sure, but in mine it was more simplistic, like they're too overbooked and I can't get you in, as opposed to.
I mean but that's not incorrect either. Too,
Yeah.
there is a wait.
Until they have all
They can't get scheduled, and that was sort of the
Yes,
beginning portion of the
yes.
explanation why we had that. This is within our control.
Yes.
The overwhelming volume that we get sometimes isn't necessarily. That's not within our control. There's limited number of resources within the hospital setting. There's a limited number of providers, and then there's the truth that all of these hospitals, places in Southern California, as sort of a last resort, when they can't be treated in their more local areas, they have to be referred here. Which is why we have lots of consultations, but they don't always come for them.
I think you did, yeah, good job at finding a little piece of